everyone, and welcome to the City Club Forum, now the longest uninterrupted weekly forum series in the country. I'm Herb Cam, president of the City Club. Our speaker today is Dr. Richard E. Behrman, Dean of the School of Medicine of Case Western Reserve University and professor and chairman of the Department of Pediatrics at Case Western Reserve. And that is only the beginning of a long list of impressive credentials. Dr. Behrman also serves as director of the Department of Pediatrics at Rainbow Babies and Children's Hospital, the only children's medical center in Northeast Ohio. His special areas of medical expertise are in intensive care and emergency care. Dr. Behrman is chairman of the National Academy of Science Board on Child, Maternal, and Family Health. He also served as a consultant to the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. He is actively involved in a number of programs for regionalization of health services in northeastern Ohio. I might tell you that Dr. Behrman attended Amherst College and received his medical education at the University of Rochester School of Medicine and Johns Hopkins Hospital in Baltimore. Before joining the faculty of Case Western Reserve University, he was professor and chairman of the Department of Pediatrics at Columbia University in New York and Columbia Presbyterian Medical Center. His subject, slightly different from that advertised, medical ethics at the bedside and public policy. It is a great pleasure to introduce to you Dr. Richard E. Behrman.
Thank you very much. Today I want to talk to you about medical ethics and how public policy shapes the ability of medical practitioners and medical researchers to do their jobs ethically. In other City Club talks I've heard, the speakers have provided answers to important county issues, to foreign policy concerns, and national economic questions. In contrast, perhaps, to these talks, I will not be presenting solutions to problems, but rather I will be discussing an approach to these issues. I'm going to start off this afternoon by telling you a tragic story about a family. A story which touches on several matters I would like to consider with you today. This family was in an automobile accident. The father died, the mother suffered lacerations and serious fractures of a number of bones. She also had been pregnant and lost the fetus and had to have her uterus removed. The couple's only other living child, who had been in the car with them, suffered multiple serious injuries, including severe head trauma with brain damage. Before the accident, the child had been entirely well. The couple's other child had died a year previously from a complication of a tonsillectomy and adenoidectomy operation, TNA operation. The injured child required total life support and was on a respirator in coma. The family was of modest means, but had been caring for an elderly grandparent who lived with them. It was not possible, as it rarely is, to predict with absolute certainty the degree of residual brain damage or brain function that would be present if the child survived. However, on the basis of the diagnostic studies available, some of the most sophisticated that are presently available, and the child's clinical course, all of the experts thought that the brain damage was catastrophic and that chances of ultimate survival were very small. However, the child could be kept alive for several weeks probably, with total life support. The child was not yet technically brain dead, but this was very likely to occur sometime in the next few weeks, it was thought. The mother was incapacitated by her injuries, depressed with grief. She wanted very badly to see the child, to be taken to see her child, but would not probably be able to do so for about a week because of her own condition. The mother's physicians argued that for her sake, the child should be kept alive as long as possible with whatever extraordinary measures were necessary in order to give her a chance and them a chance to help deal with the problem with the mother. The woman was in no condition herself to be adequately informed about the details of the child's condition. She could not, therefore, give informed consent to anything. The grandmother, an intelligent and devout woman, wanted everything to continue to be done for the child, no matter how small the chance of survival or how great the injury. She feared the impact of the child's death on her daughter and believed it would be morally wrong to do anything that might decrease the child's chance of survival. She did indicate that her daughter did not share her own religious convictions. Now, in caring, I'm going to keep coming back to this case during the next half hour. In caring for patients such as this child and his mother, and in conducting human investigation, physicians face choices requiring an ethical stance. Ethics permits a judgment of what is right or wrong in patient care and in research. However, various public policies may affect or constrain the physician in making ethical decisions, or may promote the physician to make ethical decisions. Specifically, economic policies which give high priority to cost-benefit analysis in making medical decisions, and policies about the regulation of research, may be constraints on ethical decisions. I hope to make this clear by returning to the case I just presented to you throughout the talk. The sole surviving child suffered serious brain injury from an automobile accident and required the most advanced level of medical care to be kept alive for only several weeks. During this time, his incapacitated mother might have a chance to see him and adjust to the catastrophic situation in which she found herself. What if the child had been severely mentally retarded to begin with, rather than a normal child? Should it make any difference if this retarded child, if he had been retarded, had a totally curable or an incurable disease? What if there is reasonable certainty that the duration of survival will be very limited after providing the intensive care for the acute problem, but that the patient will be able to enjoy some period of time of life during, even though it's limited in duration? For example, what if a patient is an 85-year-old adult with a painful and curable cancer and a limited time to live, who nevertheless, with sound mind, expressly indicates that she wants to be kept alive at all costs, to have one last Christmas with the family? Another actual case. What if the patient was the same situation, but it's a 35-year-old mother of 4 rather than the 85-year-old lady? Should it make any difference if the patient can pay for it all, even without insurance, or is destitute? What if the family who will have to pay does not want the intensive care because it will be bankrupted by the expense? Would it make any difference if the patient agreed or disagreed? These kinds of questions are not just matters for general theoretical discussion. They are illustrative of the kinds of questions that must be considered, answered, and acted upon many times a day in most hospitals. Even if they are not asked, action will be taken that answers the questions. Ordinarily, a number of interrelated factors must be taken into account by physicians in such cases as that of the family I've described. For example, the nature of the medical problem itself, the catastrophic brain injury in that case, the associated mortality and morbidity risks, the likely duration of life and disability. In the child referred to, the likely duration was short and the likely disability very great. The certainty or lack of certainty about the illness and the injury and its consequences. We do not usually deal with situations when one can be 100% certain about the predictions, including the case that I mentioned. Rather, we often are making judgment about probabilities. Another factor, the pain or discomfort involved in the injury itself or the illness, and the pain and discomfort involved in its medical treatment relative to the length of survival. The risks of the medical treatment itself, the patient's mental capacity, and the patient's ability to give informed consent. The attitudes, feelings, and ethical value systems of the patient, the family members, the physician, the nurses, all of which may be different from each other. In this case, the mother and grandmother disagreed about continuing life support at a later point in the case. The cost of care to the individual and to the family, the potential human and financial cost of not giving intensive care, and having the patient survive with a severe long-term disability which was not predicted and might have been lessened by the intensive care. The cost to society of expending resources on intensive care for the few rather than using them for preventive programs for the many, like hypertension screening. Now, we educate physicians and expect them to become skilled in weighing all of these factors in order to make the best decisions they are capable of making under the circumstances for the benefit of the patient. It is into this area of physician judgment that public policy intrudes, with the requirement that cost-benefit analysis criteria be used in making decisions. First, what are the ethical dilemmas posed by requiring that we ultimately decide medical problems by balancing an evaluation of health care costs, in this case the additional week of intensive care for the child in the car accident, against the relative personal health benefit to the patient or the family derived from expending these funds, the mother's opportunity to visit the child before death? The notion of applying a cost-benefit analysis must first be translated from something applied to an inanimate system or a hospital to what it may mean for an individual living patient and the family. For example, the situation of the family I described. The child required intensive care, high-technology diagnostic tests, and total life support, including artificial ventilation. The cost of such care would easily rise to over $1,000 a day. Should these costs make a difference in how long he is kept in intensive care, or what is done there if the physician's best judgment is that it's needed medically? Would you have applied a cost-benefit analysis to this situation to decide when to stop providing life support to the child? How would you value the benefit from continuing life support for one more week, and how would you weigh this against the financial costs in the intensive care unit? Are you willing to make these decisions indirectly by supporting public policy that will make fewer facilities available? The same ethical issue is involved. Do we want physicians to use an accountant's cost-benefit analysis approach to making important medical decisions any more than we want them to mechanistically use scientific formula in deciding things? Don't both approaches eliminate the essential areas of human sensitivity, tolerance and judgment, and perception about complex human interrelationships and values that are of the most important qualities we want in our physicians? This example of the possible variability and range of factors to be considered in one family tragedy in which a policy of cost-benefit evaluation will have to be applied also raises the basic question of how much health care and its technology should any individual be entitled to. What if we're not talking about life and death, but rather another costly test to further reduce the statistical probability of missing the detection of a cancer when an earlier test has already been negative? What if the additional costly test to be employed is to increase the chance of detecting some far less serious abnormality that, if undetected, will only cause minor discomfort or minor disability? Many believe the real inflation of healthcare technology costs has not been in the unrestrained cost of the big technology like CAT scanners and intensive care, but rather that of the inappropriate and injudicious, although well-intended, use of small technology many times a day by many physicians. I'm referring to the common laboratory tests and x-rays. In either case, the ethical issues underlying the application of cost-benefit criteria to medical decision-making depend upon whether healthcare services and technology are really just like other goods and services. If they are not, and if we as a society decide to ration, another word for allocate, to ration them because resources are limited, rather than provide them as a right, what ethical principles should govern this allocation or rationing? The mechanism of rationing may be by regulations, for example, cost containment policies, or by allowing the natural forces of market competition to force allocations. If we agree that at least some health services are special, such as those that are required to deal with life-threatening illnesses, the ventilator for this injured child, or those that are vital to keep us functioning relatively normally as productive citizens, then why these health care services are special suggests the ethical principle that we need to consider in deciding if cost-benefit analysis is a just or ethical criteria to use. Now, in my opinion, many healthcare services are special because they are a prerequisite to our having a fair chance to obtain other goods and services in our society. Without them, we cannot have equal access to the normal range of opportunities in life. We will be limited by disease or disability and thus not have a chance to attain the independent, productive state by the exercise of our own individual talents and efforts. If we are committed to the idea that justice and fairness requires equality of opportunity, then we cannot accept an unlimited cost-benefit measure of what is right in a given medical decision. An unrestrained, competitive healthcare marketplace cannot equitably ration or allocate these essential services. Specifically, this means, for example, that because the poor in our society will lose access to equal life opportunity without some level of guaranteed essential health services, an ethical public policy, whether based on regulation or competition or some combination of both, should provide these services in some manner to this group. It would have been unjust to have provided less to the child in intensive care than was provided because his mother was on aid-dependent children. If we cut back Medicaid and reduce the ability of those few hospitals who care for most of the poor to pay for this care by shifting some of the cost to paying patients, but fail to provide another way for all to have equal access to these special services, society is failing to provide what the philosophers call distributive justice, and the physician will be pressured to act unjustly by social policy. In effect, we will have institutionalized a two-class healthcare system in which the poor of our population will not have appropriate access to those special health services which are essential to having equal opportunity in our society. Now, please do not misunderstand me. The present partially regulated system for healthcare leaves a great deal to be desired, and a more market-like model may have real advantages. However, we must make reasonable adjustments so that the rationing effect is justly distributed, or at least as fairly distributed as it is now, by making sure to provide for certain basic health services for those who are really unable to provide them for themselves. Similarly, under a regulated or a market system, an ethical and effective approach to the very real problem of unnecessary use of small or large technology is not to regulate the development, diffusion, or access to technology. Instead, we must reshape our economic incentives to use technology wisely. Medical educators must instill in medical students, residents, and practicing physicians a sense of the importance of restrained, selective, intelligent use of technology in patient care. We should not reward the physician for unwise decisions to employ certain technology, nor punish him for wise ones. In summary, then, the ethical issue underlying the cost-benefit criteria is whether essential health services can be distributed justly. Is there some means besides what presently exists to pay for providing these services to those who cannot pay for them? The physician and society cannot ethically justify withholding such services from any patient primarily on the basis of cost-benefit analysis. I'd like now to turn to a very different ethical issue in medicine today. In the family I presented initially, there was a child who died from a tonsillectomy and adenoidectomy, a TNA. I referred to this as an unnecessary procedure and thus an unnecessary death. If there is a question about whether something to be done to a patient is in that patient's benefit, isn't there an ethical obligation to find out whether it will be beneficial? This is the basic ethical issue underlying research in humans. The practice of medicine requires continual critical reevaluation of what we think we know in order to apply what we know to the prevention and alleviation of pain, suffering, and disease. Honesty is at the very heart of this process. Honesty about what is known and what is unknown. Honesty in making observations about the patient's condition, honesty in admitting errors in judgment, and honesty in identifying the various interests and concerns of the patient and those involved with the patient. We look for honesty, sensitivity, caring, altruism as essential characteristics complementary to intellectual ability and performance in selecting students for medical school. Physicians, to be worthy of their trust, should have a commitment to attaining more knowledge, more understanding, and experience for the specific purpose of helping others. This involves a commitment to knowing the truth about the biologic world, and this requires research and has led to misunderstandings about the ethical role of medical research on patients in our society. Public policy influences this ethic of research by regulation. For example, an absolute requirement that research be done for the direct benefit of the individual who is the subject of the research. It also affects decisions to do or not to do research by the amount of public funds that are made available for research. Now, first, in considering research, it is important to appreciate that there is confusion of what is usual and customary in medical practice with what is safe and useful. Consider, for example, tonsillectomy and adenoidectomy, the operation that led to the death of the first child in this family I presented. How many of you have had these operations? I have. About 1 million a year are done, making up 25 to 30% of all the surgery in children in the late 70s. Set aside the financial considerations and the fact that $500 million a year was spent on these procedures that might have been saved. During the 50s, TNAs resulted in 200 to 300 deaths per year. This procedure continues at epidemic rates, though there is no evidence that it is effective, except for a relatively few uncommon conditions. The child referred to did not have one of these disorders, and in this sense, the death was due to ignorance. Doctors disagree so widely about the indications for TNAs that in Vermont there's a 5-fold variation by area of residence in the probability that a person will have his or her tonsils removed by the age of 20. Thus, we have a procedure of dubious value employed at high frequency despite significant mortality and dollar costs. It is done because some doctors and patients believe in it. It has become for them usual and customary. It has not been subjected to systematic scrutiny and evaluation, the experimental design, or research. If we add to the calculation of the deaths from TNA, deaths from other major surgical procedures of similar dubious value, and injudicious prescription of very powerful drugs, it becomes clear that the gains in public safety from the scrutiny of medical practice by requiring controlled human research trials would be substantial. Now, among the reasons given for the persistence of medical error are intentional dishonesty on the part of some physicians, professional incompetence, a lack of commitment to the public good. These factors undoubtedly contribute to a limited degree to some wrong-headedness in medical practice. However, a far more important source is simply the doctor's honest conviction that what he or she does is good for the patient's welfare. Where good evidence is lacking, the best and most dedicated of us do wrong in the utter conviction of being right. Just consider the historic phenomena of bloodletting, which dominated the best thinking in medical care throughout the 18th century. However, the ethical issues in doing research to attain more knowledge for the benefit of patients brings into sharp focus the conflict between the ethics of individual benefit, research must benefit or at least do no harm to the individual, and the ethics of group benefit. This clash of interests often neglects to take into consideration the fact that at present, each of us has benefited from the knowledge obtained from previous scientific investigations or research. This, in turn, places us as individuals under an ethical obligation to future generations. Perhaps more importantly, or equally importantly, there's a very real danger for the individual patient in not doing research. The danger may be greater than the risk to the patient in doing the research. Not doing sound research may become unethical when lack of knowledge could do harm or when the individual could lose a benefit or be subjected to an unnecessary risk. The child who died after the TNA was subjected to a risk because of the failure to carry out sound human research, which would have provided the necessary convincing knowledge of safety and efficacy, or the lack of it. Let me give you another example which illustrates how it may be unethical not to carry out controlled clinical research trials on patients. Last year, a study in England was reported. The study suggested that subclinical maternal vitamin deficiency during early pregnancy might be an important causative factor in infants being born with meningomyelocele. A meningomyelocele results from a failure of the spine to develop normally around the spinal cord. The defect is frequently associated with severe crippling, hydrocephalus, mental retardation. A group of women who had previously given birth to one or more infants with these problems and were planning another pregnancy agreed to enter the study. They were fully informed of the possible benefit to them and their fetuses in taking the vitamins. There was no known risk at the time from the vitamins. The women agreed to take the vitamins in the study because of the possible individual benefit to them. In the study, some of the women received the multivitamin preparation for a specified period before and following conception. Others did not. Only one affected infant was born to the group of 178 who received the vitamins, while 13 were born to the other group who did not. And this was the normal recurrence rate for such a group. Thus, the most straightforward interpretation was that the vitamin supplementation had prevented some cause of malformation. However, the validity of the study depends on the assumption that all the mothers were at equal risk for conceiving another affected child. On this point, unfortunately, there must be some doubt. The vitamin-supplemented group were recruited on the basis of their ability to adhere to a fairly stringent regime of tablet taking, while the other mothers were chosen from those who would not or could not take the tablets. Thus, self-motivation, self-discipline were involved in the selection of those who took the vitamins. There is a great deal of evidence to indicate that such self-selected, highly motivated groups of women have a better than average outcome of pregnancy. They tend to be different in education level, social economic class, and may, in fact, have a very different biologic risk. Therefore, the treated group did not have the same underlying risk of having a child born with a spine malformation. So what does it matter? The results are striking and argue for providing immediate vitamin supplementation to all mothers who are at risk. If vitamins were completely harmless, one could perhaps give them to all mothers. However, there's now additional evidence that components of this same multivitamin preparation can themselves cause malformations of a different kind. There's a very real but different risk involved in giving the vitamins. Thus, the doctors and the patients now face a dilemma. If they ignore the results of the study, they may allow the conception of fetuses with malformations of the spinal cord that may have been prevented. If they advise supplementation to all would-be mothers, they may contribute to the induction of a different group of abnormalities, whose appearance may not be recognized for some time. This kind of ethical dilemma could have been avoided by scientific human research, a controlled randomized trial. There is an ethical responsibility to attain knowledge. The knowledge of this kind can only be obtained through research which involves some limitation on the individual benefit criteria because of the greater risk of harm to the individual from not doing the research, from not knowing. In addition, there is a need to give some weight to the ethical interests of the population as a whole, as well as to fulfillment of our individual obligation to future generations. We must take these interests into consideration in deciding how much public money should be devoted to research. If such monies are not provided for research, physicians are forced to make unethical clinical decisions. I realize in making this presentation to you, many questions have been raised, and I have provided very few answers. This has been intentional on my part. Complex human problems involving important issues of health and survival, which may occur with unlimited variation, often do not lend themselves to simple calculations which add up to what is right and what is wrong. When I started this talk, I warned you that I would not be providing solutions to problems, but rather approaches to issues. The very nature of the decision-making process in ethically caring for patients is that although one sets out to answer a particular question which leads to a decision, the answer can only be applied to other situations to a very limited extent in a society that places the highest value on individual life. This occurs because of substantial human variation in different clinical situations and of the biologic variation among individuals. There is, however, a way of approaching the analysis of such problems by applying certain ethical principles of fairness, equity, or distributive justice and honesty. The public policies that promote unrestrained cost-benefit criteria for making medical decisions, and other public policies that strongly discourage human research, may adversely affect the ability of physicians to practice medicine ethically, as well as affect the quantity and quality of patient care in our society. Thank you.
Thank you, Dr. Behrman. Today at the City Club Forum, we are listening to Dr. Richard E. Behrman, Director of the School of Medicine at Case Western Reserve University. In just a few moments, we'll have our customary question session. First, some few brief announcements. Let me remind you once again, ladies and gentlemen, and especially those who are listening to this forum on television or on radio, that the membership drive of the City Club and the City Club Support Foundation, or the City Club Foundation Support Drive, are currently underway, and we do need your support. As a matter of fact, in our main dining room next Wednesday evening from 5 to 7 p.m., there will be a Salute to Cleveland party to greet new members and to have you meet the officers and other people connected with the City Club, and I would cordially invite all of you to attend that function. Today, as always, we have students with us who are participating in our Living Seminars program, which we sponsor in cooperation with the Cleveland Public Schools and with the support of Sohio. With us now are students from the following high schools: Fairview, Glenville, James Ford Rhodes, John Adams, Lincoln West, Mid-Park, Olmsted Falls, and Padua. Would you please rise and receive our welcome? These students will be meeting us with Dr. Behrman for a seminar of their own following our club forum. Next week, our speaker will be George A. Daly of the Civil Aeronautics Board in Washington. His subject will be Sunbelt versus Snowbelt, the role of transportation. Be sure to make your reservations today for this important address next Friday here at the City Club. Now for the question period, we have two microphones, one up front with Alan Davis, one in the rear with Bob Cavano. Raise your hand to be recognized. Let's have the first question, please, for Dr. Behrman.
Dr. Behrman, I enjoyed your talk, especially since I'm convinced that I'm in favor of everything you've said.
That's a good way to start.
I wonder if you would agree with my proposition. You've outlined the frustrations and the paradoxes and the terrible situations that a physician faced with a judgment has to make. Wouldn't it lessen your burden? Wouldn't it make it easier for physicians to act in situations of that sort if he were given some comfortable, not carte blanche, but some protection from legal strike back? I feel very strongly about this. I know that physicians' judgments are tempered in some way by the fear, or at least the thought, of lawsuits. And certainly, especially in the situations that you outline, wouldn't it be a just thing and a helpful thing if the physicians already certified and qualified to act in the capacity that they're acting, given some sort of partial immunity?
That's a sleeper question. I thought he was going to start out being a friend. Unquestionably, physician decisions are influenced by the threat of suit. Let me take it in a not quite so dramatic as life or death situation. There are undoubtedly, and there is really evidence, some objective evidence to this effect, many more x-rays taken, skull in pediatrics, skull films, than are needed to be taken or that are indicated medically because of the fear of suit or having missed a fracture, because there have been cases in which, although whether or not the fracture was related to the outcome, the physicians have lost malpractice suits because they didn't get an x-ray. Now, on the other hand, however, obviously we're dealing here with the interests of the benefit of that particular patient that the physician is dealing with, And then there are other interests. And clearly that if one gave, no one I think would conceive, any kind of general immunity, you would deprive citizens of another area of their rights, which are based on other ethical issues, to be able to remedy wrongs that they think have been done to them. A balance clearly is necessary. I suspect the pendulum has gone too far. It turns out that in most intensive care settings, where there is a lot of expertise, it's probably that's the area where there is the least likely that the threat of suit is going to be involved, is going to influence the physician's judgment, because you have many experts there. It's a totally open situation. You're likely to be documenting everything that's going on, and the mix of reasons are well documented that go into the judgments, and that really gives you protection in terms of a suit. Now, that doesn't stop people from suing, but I think it probably in that arena, physicians are less likely to make bad judgments than in some of these less life and death threatening. I haven't really answered your question, because I'd have to think about that a bit more.
Regarding your term of distributive justice, I wonder if you could possibly expand a little more on that in relation to something that was on nationwide TV within the last month, I believe. And this pertained to the treatment of premature babies, where with technology as it is, we are able to prolong life on babies much longer than we could, but it also runs up. They had one couple on there where the bill, as of now, it was something like $100,000. Because of the premature baby, there was all sorts of complications, and really the parents did not wish to continue the life of that child because of the effect on the other children in the family, the economics of it. And what are we really doing to approach this, as you started to talk about in your prepared remarks?
Well, I think the first step is to identify, is for the general citizenry to recognize the nature of the problem. And I think in that sense, there is an advantage to the press and TV and other groups bringing to the attention of the public the dilemmas that are involved, because we aren't going to solve the problem until we all agree there is one. Now, moving away from that and trying to deal a little with the substance that you raised, the problem in our society is that the parents' budget to pay for that, or the hospital's budget to pay for that, or even the state's budget to pay for that is an annual budget. For society over the lifespan of a 70-year life expectancy, that may be a very cost-efficient thing to do, to have a $150,000 bill for a premature, because the consequence of not having it may be that premature survives with damage that costs society 10 times that much over the life of that child because he's institutionalized. Now, obviously, the problem is that the state government and the hospital budgeters and the administrators and the family are not worrying about what their budget's going to be 10 or 15 years from now in taking care of that child. They have to worry about right now. And so, in a sense, we haven't dealt with this problem in a rational fashion. Now, the evidence is at the moment that significantly less long-term damage is occurring, even in very premature and very ill children, as a consequence of the intensive care. And therefore, we imply that we are really saving the total society something in the long run. But that doesn't help in that particular situation for that person. And remember, what I'm talking about is generalization. That doesn't mean there aren't going to be some that you spend the $150,000 or $100,000 on after 3 months in the hospital, and the child comes out and has severe disability and damage, and still you have all those other costs. But it means that in a statistical sense, it has improved the situation.
Doctor, has the Hippocratic Oath been amended and brought up to date, or is it still relevant as written?
I think it's relatively the same. I'm sure, I think some of the terminology has been changed to modernize as used, but it's not substantially different. And don't ask me to recite it.
Doctor, part of the impetus towards a relatively heavy-handed and perhaps bureaucratic regulation of medicine has come from the explosion in healthcare costs. Since you seem to be advocating a more sensitive and individualized approach, do you feel First, that there is anything that the medical profession itself can do to respond to the rapidly escalating costs. And secondly, if you do think so, what would it be that the profession can offer?
Well, I think that the profession can do a lot in terms of its increased awareness and understanding of the ramifications of medical decisions on cost, particularly in those areas where the evidence supporting the benefit from the thing that they're making a decision about is very marginal. Now we fall into the range of education. I think you have to start this with medical students. I think you have to continue it with continuing education. Much of continuing education that goes on, and I can tell you there are literally hundreds of sessions in this city in the course of a year to re-educate physicians, pay very little attention to this. In general, it's focused on making them as aware as their patients are of what the latest thing that occurred in the magazine. Unfortunately, I mean and therefore the business of getting to making people increasingly critical about the use of the customary versus the proven remedy is an important continuing education activity that should go on. And I think that could be re-emphasized and the emphasis changed so that it was much more effective in controlling this. I think there's been a change because of the general awareness of the limitations of resources and what this is going to mean. The underlying problem is a much more difficult one. And I don't want to pretend to say that there aren't injustices that occur in rationing care today. There are. If you happen to be born a premature infant and you happen to be born by no fault of your own or your parents prematurely and you don't happen to be where an intensive care unit is, your chance of coming out whole is not the same as if you happen to be born where the intensive care unit is. The answer to that is not to have intensive care units for neonates in every hospital in every suburban and rural community. It probably relates to transportation systems, probably really relates to putting money into preventive activities which will decrease the incidence of prematurity that nobody wants to put the money into right now, despite what is publicly said.
Dr. Behrman, with this complexity of ethical considerations which seem to be growing constantly, what is the medical school doing and how is the educational process changing to consider this in order to help these students who are going to have to deal with these problems?
Well, we do several different things. One, in our own selection of medical students, we pay a lot of attention to the nature of their background and that it not be a background which is exclusively scientific. We want them to have a sense of society. A liberal arts education, I think, is the best possible background for medicine. Secondly, we have altered the curriculum, as have many medical schools, to have a greater input both from non-physician, religious leaders, ethicists, philosophers, right from the start of medical school, along with physicians in case solving, in working through these kinds of cases like I present, so that people begin to get a background of experience in thinking through the problems from a total situation point of view, not just from the point of view of the particular medical technicality involved. I think that goes on in residency training in most of the university settings. It unfortunately drops off very markedly when people go into practice by the nature of making a living in practice, and therefore it's at that level that I think we probably need to re-emphasize it in the continuing educational arena. But I think there have been a shift. I think we've probably shifted here more than most other medical schools in the direction of building this into the education system.
Dr. Behrman, Dr. Caldecott recently addressed the club, urging us to demand a total, universal, and verified elimination of nuclear weapons of war. Do you agree with Dr. Caldecott, and do you believe that physicians, because of their special competence in judging the consequences of such a war, ought to demonstrate support of her stand?
Well, she says many things, so that but basically, I do agree with her stand. I mean, I think that it is, as a matter of my personal conscience, I agree with being in favor of those things which will limit the potential for what I believe is significant destruction of the species and that are at risk to the survival of the species.
Dr. Behrman, if I understand the last proposal, that suggestion that you made, I can also understand the troubling elements of, to some, for that sort of a proposal, which, as I understand it, is the greater good to the greater number, and therefore some unfortunate consequences for particular individuals. And without intending to make this more dramatic than it might sound, that concept, it seems to me, might have been used by some physicians in countries such as Germany at times in terms of how they dealt with patients for the greater good of a greater number. That seems to me to be a real concern. How would you deal with the controls that would handle that proposal?
That's a very good question, and I want to make myself clear if there was any misunderstanding. I do not think that an unrestrained ethic that basically gave the highest priority to the greatest good for the greatest number would be appropriate in medicine. I think that clearly the weight of the emphasis on what's ethical has to be towards what will benefit the individual. And we have to do anything in which we move towards the other direction has to a substantial degree, depend on making the individual aware that they are choosing personally to fulfill their responsibility to the subsequent generations and to society. So one of the best controls clearly is involved informed consent of the individual to participate. That informed consent will result in more people participating if more people understand the ethical issues and the importance of that participation, both for themselves and for society in general right now, as well as for future societies. Because the problem today may be tonsils for one person, and it may be hysterectomy the next day for someone else, neither of which we might have the database to decide whether it was really a sensible thing to do. Certainly the slippery slope argument is one in a free society, the one you were referring to, is that we all have to be concerned with. Interestingly enough, however, in the case I gave you of the women who entered the study, there had been an ethical committee that had agreed to the study. I would argue that committee was unethical because they allowed the study to go on, which couldn't give an answer, and laid them open for a subsequent problem, creating a dilemma. Now, obviously there isn't a simple answer to your question, and I think we are constantly in our society weighing different interests, rights of individuals versus rights of the state, etc. And I think we should be doing that in this situation. And the only thing I would argue against is creating legally a structure which doesn't allow us maximum freedom in weighing those interests in an individual situation. I would argue for the common law situation in medicine rather than for the Napoleon Code.
Dr. Behrman, you raised a whole host of complex ethical questions, and I wonder, I believe that perhaps the present way those questions are being resolved is partly through the individual conscience of the individual physician, partly by boards of trustees of hospitals, and partly by the code of ethics drawn up by the American Medical Association. I wonder if a more proper way of handling it might be through some kind of a statute adopted by the state legislature or by Congress, and if so, whether the American Medical Association or the medical schools would be willing to lobby for such laws to provide guidelines.
Well, frankly, the answer to complex problems involving human services is to always go to a legislative solution, because my own sense of the way in which legislation works best is not in dealing with lots of particular situations. And I think it would be, that's not to say that might not be a way. I mean, I haven't thought of or whether we could put together some generalizations, but in general, I think that you're much better allowing these things to be done in a multiplicity of ways in the voluntary sector, with people feeling fiduciary responsibility for what goes on in the settings in which to which they're closest. Now, that doesn't mean I would be against elimination of ethical committees. I think there's been really a major improvement in the ethics of medical research, for example, by the federal legislation that has put into place ethical committees. However, if you were to say to me, should they make a book full of regulations telling those ethical committees how to solve the cases that come before them, I would say no. It seems to me that that would probably end up in more errors. The issue here is how do you make fewer mistakes? Because we're going to make lots of mistakes in almost anything when we're dealing with human problems. And so we want a situation that will try to decrease our errors. And I think you probably have fewer errors to do it closer to where the problems are and to have multiple groups worrying about it, rather than to have at one time the legislative worrying about it, putting something down, and then subsequently it has to be applied. I think that's probably you'll make more mistakes that way in this kind of problem solving.
Dr. Behrman, away from the philosophical for just a moment.
Good, I'm almost over my depth here, I can see that.
Doing very well.
If not already.
Do you think that the final results are in yet as to the benefits to the patients of a cardiac bypass surgery? And do you see any similarity at all between the great popularity of that type of surgery in the last decade and the tonsillectomies and the adenoidectomies you talked about earlier?
I thought he was a friend. I think there is some similarity. I don't think it's like the tonsillectomy issue, and I don't think it's like the hysterectomy issue. However, I think there is more controversy and more question than one would come away from the TV program last week thinking there was. Now, that doesn't mean that I think that people should not have bypasses. There clearly are clear-cut indications for certain groups of people. There's clearly another group of problems that it's not at all clear, and there's some that are being done where they clearly should not be done. And I do think we need more investigation in this area. It may well be that other modes of therapy catch up and pass bypass surgery before we actually settle whether it's useful or not. There are 2 or 3 other areas in which things are going on in terms of other approaches to this problem that may, in fact, make it obsolete. But the issue that you're raising, do I think that I do not think that we have a problem here that is solved. And I think the impression I came away from the TV program the other night was that it gave the impression maybe, although it raised the issue, the Harvard group was questioning it, that maybe it was a little more settled that it was a good thing or a right thing than it really is. That's not to say that many of them that are done are unnecessary, because I think many of them are necessary. So I guess I'm a little in the middle there. I'm waffling. I'm not totally convinced. I don't think it's like the TNAs, but I don't think it's like cholecystectomy for gallbladder disease.
Dr. Behrman, going back to the subject of research just a moment, and let's just take the area of cancer research. I would assume that in the United States there may be dozens and dozens of hospitals that do cancer research. And I would assume that there is a coordinating body, which I would say is the National Cancer Institute, that coordinates all of the research projects that are taking place in the country on cancer. Now, when you compound this with how many countries in the world must also be doing similar research, the layman would assume that there are probably experiments going on several places in the world that are just duplicating the efforts. Is there, for example, a world coordinating body? There may be a doctor in Namibia who has found a cure for lung cancer that no one knows about. Can we assume that there is some kind of national as well as international coordinating body that is in any way working towards a unified effort in solving that problem?
If what you were saying is there something for on a worldwide basis equivalent to the Cancer Institute, which coordinates all the clinical studies in this country? No, there isn't. Not in a sense of a very firm, but there is a lot of communication, and there are at least 3 organizations that try to coordinate things internationally. And in given areas, you can't say for cancer totally. For example, leukemia, there's a lot of coordination worldwide. Another cancer, there may be somewhat less, or it may be less important that it is because there may be less research going on in that area. So it's certainly not a perfect system or a totally organized and rational system, but there is a fair amount of coordination through the informal networks in the sense of there is a lot of customary ways of communicating that are very effective in the scientific world, and by and large, that guarantees that people know relatively soon where there is a sound reason for knowing that there's something new on the horizon. Now, the problem is that that system, which is not as neat as for example, like the National Cancer Institute, has a lot of security built into it, because one of the problems in our society, with due respect to the media, is that information goes too fast before there has been the normal checks and balance and critical evaluation of the information. It becomes very common to lots of people, and you could say that's a benefit in a free society. However, it puts those people at more risk. And I would just be concerned. I'm not sure we may need some more communication on an international level, but I think that there is substantial, although it's not in as neat a package as one might design from the start.
Dr. Behrman, I am not a doctor and among all these groups of medical people, but I am looking at this problem from perspective of a consumer of a lot of medical help. As a senior citizen, you brought the problem up of the child. How much, well, what I'm getting from it was, when do you stop that life, or when do you let that life keep on going? I'm looking at it in terms of what it does on a family, not only economically, but also mentally, the mental anguish. And in looking at that particular problem, I was wondering, I said, now why would they want to wait to hold on to this child that eventually might die in a short time, or if it does live, it's going to be a vegetable or something the mother's going to have to cope with later. Why would they want to just keep on giving artificial life to this child when this mother's had all these problems? Supposing that child had been killed outright while that mother was sick. She couldn't have done anything about it then. I've had similar experience in my own family. I have a sister now that is mentally incompetent because she had a son that she had to, that was allowed to live for years. And so this is one of my problems.
Unfortunately, I'm going to have to interrupt you because they've just given the signal, and maybe I've been saved by the signal from answering a very good and very difficult question. And perhaps we could talk about it after we go off the air, and because I think it's wrap-up time.
Thank you very much, Dr. Richard Behrman, Director of the Case Western Reserve University Medical School. Today's City Club Forum is adjourned.